An Approach to Chronic Obstructive Pulmonary Disease, presented and narrated by Brennan Quiney of the University of British Columbia in collaboration with Dr. Nasir Jaffer, Mount Sinai Hospital, Toronto, Ontario. Diseases falling under the diagnosis of COPD are characterized by the presence of a progressive airflow limitation that is not fully reversible. This implies that neither current treatment nor abstinence from the precipitating factors will completely halt disease progression. COPD encompasses two disease processes. These are chronic obstructive bronchitis and emphysema. Just as COPD is a rather heterogeneous diagnosis, patients often present in a heterogeneous manner with elements of both disease entities. Contrary to the majority of diseases we treat as healthcare professionals, COPD has actually increased in both prevalence and rate of death over the last 20 years. At the current rate, the World Health Organization predicts that by the year 2020, COPD will rise from the sixth most common cause of death worldwide to the third. The first disease entity of COPD, chronic obstructive bronchitis, involves the small airways of the lung. Anatomically, these are the generations greater than the fourth, which have diameters of less than 2 millimeters. The pathophysiology of this disease is best demonstrated in smokers. Inhalation of tobacco smoke leads to a dysfunction and eventual loss of the ciliary mechanism of the lung. This results in decreased mucus clearance and buildup of mucopurulent material, leading to inflammatory infiltration of the airways. The progressive dysregulated immune response provokes airway remodeling, leading to narrowing and disease progression. Emphysema is a destructive process of the lung parenchyma, leading to enlargement of the air spaces. It is classified into three groups based on anatomic predilection. These are Centrilobular, panacinar, and Paraseptal. Note that panacinar is synonymous with panlobular. The proposed pathophysiology involves an imbalance of tissue metalloproteinases and their inhibitors in the lung tissues. The most common mechanism to explain this effect is related to dysregulation of immune function by tobacco smoke or a lack of functional inhibitors seen in the familial disorder alpha-1 antitrypsin deficiency. A possible diagnosis of COPD should be included in the differential of any patient presenting with dyspnea, chronic cough, sputum production when accompanied by risk factors for COPD. These include known family history of alpha-1 antitrypsin deficiency, smoking, and exposure to occupational dust, chemicals, and fumes from combustion of heating fuels. Note that these findings are neither sensitive nor specific. When COPD is highly suspected, the diagnosis should be confirmed with the use of spirometry and imaging. Imaging serves to further increase diagnostic confidence by providing objective evidence to the clinician. This is particularly helpful in the setting of acute exacerbations, where a current film may be compared to the baseline images in order to stratify severity. Serial imaging over the patient's course of recovery will also guide clinical decision-making towards disposition. This approach is also used to monitor disease progression and surveillance of associated comorbidities such as lung cancer. Treatment of COPD generally proceeds in a stepwise fashion. Patients should initially be given a correct diagnosis and educated about their illness. Regular appointments should then be scheduled with both primary and specialized caregivers. Next, patients should slow disease progression as much as possible through the elimination of risk factors and yearly vaccinations. As symptoms progress, a short-acting bronchodilator may be added as needed. This is switched for one or more long-acting agents as symptoms become more concrete. If symptoms persist or worsen, one may consider adding theophylline. More severe diseases will require the addition of inhaled glucocorticoids and finally home oxygen delivered by nasal cannula or face mask. End-stage disease allows for the discussion of surgical options including lobectomy, lung volume reduction surgery, and lung transplantation. Patients suffering from COPD will receive multiple imaging studies over the course of their lives. Imaging will help with diagnosis, management of exacerbations, and surveillance of disease progression. The majority of these studies will be plain chest x-rays and CT scans, while there is also some role for ventilation scintigraphy. High-resolution CT scanning is also indicated in the evaluation of COPD. This type of CT scan uses widely spaced, thin slices in the order of 1 to 2 millimeters with a small field of view. These images are reconstructed in such a way to maximize spatial resolution within each slice. Due to the spacing of each image, only about 10% of the entire lung is visualized. As an aside, several academic and research-based imaging techniques are currently being used to study COPD, and these include helium isotope MRI and optical coherence tomography. Plain film chest X-ray is the first imaging modality which should be used in patients with known or suspected COPD. Here is a typical chest PA and lateral film of a patient suffering from COPD. Note first the general barrel shape of the patient's chest. The patient's lungs are severely hyperinflated with the 10th anterior rib crossing the right hemidiaphragm. There is also an increase in the retrosternal airspace and flattening of the diaphragm seen on the lateral film, consistent with hyperinflation. In the upper half of the lung fields, one can appreciate a generalized lucency when compared to the lower lung zones. Also note the tapering of the vessels as they approach this area. This appearance is consistent with emphysema changes. CT scan is the second-line imaging modality used in COPD. It is often an important adjunct to plain film in order to properly characterize lung parenchymal patterns and findings. Here is an example of a PA chest film and companion CT slice from a patient suffering from severe centrilobular emphysema. Again, on the chest X-ray, note the hyperinflated lungs, flattened hemidiaphragms, and generalized increased lucency. Although the findings are quite striking on the plain film, one would want a CT scan in this situation to truly appreciate the extent of disease. Have a look at the image on the right. What do you see? The image on the right is a standard CT scan, displaying large cystic areas representing the destructive process of emphysema. This process is diffuse and likely represents end-stage disease in this patient. Ventilation scintigraphy, or VQ scanning, is a nuclear medicine technique which can also be used in COPD to provide functional information. This technique involves both the injection and inhalation of separate radioisotopes, which emit particles of different energies. Typically, the inhaled isotope is xenon-133 gas, and the injected isotope is technetium-99. This information is captured with the use of a gamma camera and then used to create separate images of the overall ventilation area and vascular perfusion of the lungs. These scans can be compared to look for deficits which may represent areas of disease. VQ scanning can be used in late-stage disease when transplant is a consideration and will often be performed post-transplant as well. In this particular set of images, we can see a large defect in ventilation of the superior right and left lungs. Note that the perfusion to these areas is also decreased. These findings are strongly suggestive of a process such as emphysema. By far the most common type of emphysema is centrilobular emphysema. This is also the type most commonly associated with smoking. It typically involves the respiratory bronchioles of the upper and posterior segments of the lung and is most often diffuse. Panacinar emphysema is associated with alpha-1 antitrypsin deficiency. The lung involvement may be focal or diffuse and is often seen at the lung bases. Paraseptal emphysema is rare and selectively involves the alveoli adjacent to connective tissues of septa, particularly at the margins of the acinus and lobule, but also subpleurally and adjacent to the bronchovascular bundles. This type is usually not severe and is often discovered in young individuals with spontaneous pneumothoraces. Let's compare and contrast the different types of emphysema as seen on CT. Here we are presented with 4 coronal slices from a standard CT scan. The top 2 images are from an individual with centrilobular emphysema. The bottom 2 are from an individual with panacinar emphysema. The initial lesion of centrilobular emphysema is an area of decreased attenuation at the center of the secondary pulmonary lobule. This represents an area of destroyed interstitium. With disease progression, the entire interstitium is destroyed, leaving only the interlobular septum. The septae give the appearance of multiple walled-off structures within the areas of emphysema. As previously mentioned, this initially has a predominance for the upper lobes, but may later involve the entire lung, as seen in our example. The initial finding in panacinar emphysema is destruction of the entire secondary lobule with sparing of the adjacent lobule. As the disease progresses, large segments of lung are destroyed without sparing of the interlobular septa. This gives the appearance of large voids in the lungs as opposed to discrete walled-off structures. Here are two axial CT slices through the chest of an individual suffering from paraseptal emphysema. As the labels pronounce, the scan on the left is a standard CT scan, whereas the one on the right is a high-resolution CT. Note that the fine detail of the lung parenchyma is better appreciated on the high-resolution scan. Now have a look at the lungs themselves. Note that the site of disease is relatively focal, with small areas of lucency seen projecting along the interlobular septa and mediastinal pleura. Do you see anything else? Note there is aneurysmal dilation of the ascending aorta. Have a look at this CT scan. This is from a young individual who is a non-smoker. What do you see? What condition might this patient have leading to the observed findings? These are two coronal slices from a standard CT scan of the chest demonstrating panacinar emphysema. There is destruction of the lung parenchyma leading to multiple large lucent areas. As described previously, panacinar emphysema tends to have a greater prevalence for the lower lung fields. One can appreciate on these images a greater involvement of the lower lung fields with mild sparing of the upper lung fields. This patient suffered from alpha-1 antitrypsin deficiency. Alpha-1 antitrypsin deficiency is a genetic disorder in which individuals have an insufficient amount of the protease inhibitor alpha-1 antitrypsin to prevent autodegradation by tissue proteases. There are two inherited mutant alleles known as S and Z. Homozygotes of the more common S allele produce 60% of the normal alpha-1 antitrypsin. This has a negligible effect on overall health. However, homozygotes of the Z allele and heterozygotes carrying both an S and Z allele have an insufficient quantity of alpha-1 antitrypsin to protect the lungs from proteolytic damage. The specific defect in this disorder is not one of production, but rather processing and packaging. Severely affected individuals often have lung disease as well as liver cirrhosis due to an accumulation of the defective protein. Have a look at this chest x-ray. What do you see? Alright, ignoring the arrow sign, we note a hyperinflated chest, flattened hemidiaphragms, and an increase in the retrosternal airspace. Alright, now have a look at that arrow. There's a density adjacent to the right inferior mediastinum, which represents a lung mass. It's important to remember that the majority of cases of COPD involve a mechanism induced by smoking and inflammation. This also predisposes the patient to diseases like lung cancer. Case number 1. Describe the pertinent findings and choose a leading diagnosis. There is mild hyperinflation of the lungs with some flattening of the hemidiaphragms and increase in the retrosternal airspace. The patient has a general barrel look to their chest. The leading diagnosis is COPD, as these changes have a chronic appearance. However, in the acute phase, one would have to consider a reversible process such as asthma. Case number 2. Describe the pertinent findings, make a differential, and choose a leading diagnosis. Again, here we note hyperinflated lungs, flattened hemidiaphragms, and an overall barrel appearance to the chest. There is also increased lucency seen at the lower lung fields as demonstrated by the lateral chest x-ray. The differential for these findings would include panacinar and centrilobular emphysema. Which one do you think we see in this case? Given the lower lung predominance, these findings are more consistent with panacinar emphysema. Question number 1. The best method to slow the progression of the disease seen in the CT image to the right is C. Smoking cessation. Although the other treatments listed are used in COPD, only risk factor prevention such as smoking cessation has been shown to slow the rate of disease progression. For additional information, check out these resources.